Good morning, everyone. Welcome back to Donate PPE for Medical Physics Webinar 3. Today we have Siju George, Senior Medical Physicist from Miami Cancer Institute, Florida. I am pleased to welcome him on behalf of the OncoRace Foundation to this webinar. Siju is a Senior Medical Physicist certified by the American Board of Radiology with extensive experience in setting up QA protocols in various clinical settings. He will be talking about the setting up of a QA program in a multi-modality clinical setup today. Donate PPE campaign is to invoke awareness and to generate support in terms of PPE donations. The word medical physics in the campaign stands for the profession, and Donate PPE is our commitment to other healthcare professionals fighting this pandemic in the front line. Please feel free to use the questions tab to type your questions, as the microphone will be muted throughout this webinar. You can also type your message during any time of this webinar. So I thank Siju for volunteering this lecture, especially he lives in a time zone on the other part of the globe. Dear friends, please join me today in welcoming Siju on the stage by giving your full attention. Siju.
Hello, good morning, everyone. Thank you, Saju, for the introduction. Good to see that this is an opportunity for all of us to connect from different continents. I'm glad to present some of my work experience as well as the highly demanding QA, how we can streamline this and how we can use the new technology as well as the possibilities and opportunities in front of us to give the best treatment and possibly the best outcome for our patients. So my title of this presentation is one of the title that I used in a previous American Association of Physicists in Medicine meeting. I had a poster presented almost 3 years before, and I had been involved in radiation therapy from year 1998. I was a radiation therapist trained in India, moved to United States in 99, and then I pursued radiation therapy. Then I did my grad school at University of Florida. In 2007, I became a physicist and then got certification, and I continued my career as a medical physicist in radiation therapy. So I got lucky when I moved to a clinic in 2009 in Chicago area to set up the comprehensive QA program there. From then onwards, this is one of the field of my interest, along with the clinical practice that I am doing. So in 2015, by the end of 2015, 2016, this beautiful Miami Cancer Institute that you can see in the picture was instituted in Miami, Florida, which is kind of the gateway of Latin America. So we have a lot of patients. This is a 500,000 square feet building that is built just for the purpose of treating cancer. And we have a plethora of machines in radiation oncology in this department. I was one of the first hired physicists in this new facility and was instrumental in commissioning many machines in this department. So that's when our team had to come up with a quick solution of basically streamlining our QA. So let's go into the slides now. So I'm going to do a brief introduction and an objective, methods and materials, my previous experience, and our future plans. All those things I'm going to present in these slides. So implementation of a robust QA program is primary requirement for quality treatment delivery in a radiation oncology clinic. Without a QA program, a quality assurance program, and a quality control program, we physicists are not able to understand how our machines are behaving on a regular basis, where we need to pay attention, whether the plans, the beautiful plans that we are creating in our treatment planning system are delivered appropriately. So the philosophy behind all this QA/QC program is that the patients receive plus or minus 5% of the planned and the prescribed treatment. So we have a very small room of failure. So unless and until we tweak our machines to the utmost accuracy, as well as the best output that is recommended and offered by the manufacturer, we are not able to give the best treatment to our patients. So medical physics, in this evolution of new technology, came up with lot of tools and a lot of toys for us to use. So I just wanted to go through the intelligent use of it. Nowadays big data and data are too much. So where do we tap it? Where do we organize it? How do we set it up in a way that it is useful at our fingertips on a regular basis, on a daily basis? So I'm just introducing different machines that we have in our facility at Radiation Oncology Center in Miami Cancer Institute. Of course, we have 3 TrueBeams, one RadixAct, which is an Accuray machine which was named tomotherapy in its older version when it was Tomotherapy Incorporated. Now it is RadixAct. We have a CyberKnife M6 with all the bells and whistles. 2 separate HDR units. One is a nucleotron, which is also known as Electa, and variant HDR machines, Electa Versa HD machine, Electa Icon for Gamma Knife, and there is an MR Linac, and we have 3 IBA Proton machines, and in addition to that, a plethora of other type of machines like maybe 3 CT scans in our own department and ultrasound machines for image guidance, as well as for placing fiducials on the patients. So many of the other peripheral machines also are available. So configuring QA and organizing QA and checking QA on a regular basis is kind of a big challenge on this. Even if we have only one linear accelerator and an HDR machine, we have a lot of QAs to accomplish on a regular basis, daily QA, monthly QA, according to the QA protocols that we all use, TG142, TG51. I'm talking about the American Association of Physicists in Medicine's task group reports. According to that, we have to do mechanical dosimetry and imaging QA on a daily basis, on a regular monthly basis, and then quarterly basis, maybe a big QA of annual QA also. We have to incorporate all this. So how I was just talking about these task groups. Task group reports. 142 is quality assurance of medical accelerators. TG135 is quality assurance of robotic radiosurgery. TG51 protocol for clinical reference dosimetry. And then recently, the last 2 years before, American Association of Physicists in Medicine came up with clinical practice guidelines for linear accelerators. And I just put a link for all the reports. And you guys know that TG66 will talk about HDR quality assurance. TG148 will talk about tomotherapy quality assurance. So many of them are there, and so much requirements are there. And also, since I am addressing a global group, I know most of the people attending this conference will be following IAEA protocols, which is shoulder to shoulder with the American Association of Physicists in Medicine suggestions and recommendations. So technically, we all follow the requirement and the need for organizing a QA program, a robust QA program. So consolidating the quality assurance program on a multiple machine or even if it is a single machine, I'm talking about, I have worked in a facility where there is only one HDR machine and one linear accelerator and one CT scanner. And I was almost like pulling my hairs during the inspection whenever annual QA is happening. Where do I look for all this? Which is the spreadsheet? Which is the folder I have to put together? And then how I am going to retrieve all these things. So that is the advantage of having a one-stop solution. So consolidating quality assurance program on multiple machines from different vendors and to save them in a common database to review and analyze them in a timely manner needs a common platform where physicists can create tests, execute them, and review them independently. And we all know that many of these QAs are not daily on a daily basis conducted by maybe radiation therapists. Some of us are lucky to have physics assistants. Some of the junior physicists have to get trained on this. So even if there is not a common platform where everybody can access and learn and educate and empower themselves, it is so difficult to find out where these details are and how much we have to do and stuff like that. So objectives of this the project that I was developing and working was the general use of multiple, to abandon the general use of multiple spreadsheets or paper-based QA, which is a common practice, which was a common practice. I still remember when I was setting up a program in Gainesville, Florida in 2007, I still was using paper, and I have at least like 3-4 folders which I will pull every month, and then I will add a paper on top of that, and then I made Excel spreadsheets, and then finally now we have different platforms available. So then if there is a junior physicist or a physics assistant, whoever is doing this, a senior physicist or an experienced person need to evaluate, approve, and make sure everything is going well. And then before the state examination, when the inspectors are coming, we have to present our work, and so all these are going to be helpful. And you may be thinking that when we are working on a small clinic which is constrained in budget and expenses, how are we going to accomplish this? So this is a software which I want to introduce, which we are going to roll over into in the near future. QAtrackplus.com. You can see that I just have a screenshot of their front page, and that's a open source code. They have written the program in Python, and then this is QA data entry, service event log. For example, the field service engineers send reports after they do their work and stuff like that. We can actually enter all that service event log and the reports, attach the reports. You can review the data. You can schedule your QA so that we will not miss a QA at the right time. And then you can personally configure it also. And this is one of the easiest solutions we found after doing a lot of search. Actually, I just wanted to show you there are so many expensive alternatives available. If someone really want to have a configurable software, these are the options. We went through all these. Some of them sell their software for more than $50,000 to $60,000. Some of them sell it for $10,000 to $15,000. Compared to all these expenses, we can get the same or a better solution, a configurable solution using this free source code material, which is originated from Canada. And when you go to their website, you can see that so many clinics in the world are using it. Many university clinics also, like University of Utah, some of the major centers in Canada, they are well known for quality in radiation therapy physics. So many of those programs in Canada are using also this program. So after our research, I just wanted to show you the imaging QA program, which is freely available also, Pilonac. This is a open source code program also, which is integrated into this QAtrack Plus. So rather than buying expensive programs, there is free source code data, web-based data available. So rather than we went through, actually we have a program which is called Atlas that I am going to show what we are using right now. But comparing and contrasting all these products, Sun Nuclear's recent product called SunCheck, which is naturally an upgrade for us because we had been using Sun Nuclear Atlas, and normally Sun Nuclear's SunCheck will be the natural upgrade for us. But comparing SunCheck, Image Owl's Total QA, Standard Imaging's QA Pilot, Mobius, which was an independent company from Dr. Nathan Childress. Varian recently acquired that. Varian is selling it now. And then RITS, radimage.com, all those things we compared and contrasted, and we are going to roll out our QA program into this QA Track Plus, which is open source code. So we did the homework. You guys are free to take a screenshot of this and then go into the different websites and compare and contrast and identify your needs and then figure out which one you have to use. So anyway, I'm going to talk about briefly about my experience setting up the comprehensive quality assurance program. And this is the poster that I was just mentioning in the beginning. So implementation of a commercially available quality assurance database program for comprehensive QA in a multimodality radiotherapy clinic. So basically the conclusion was that Atlas, which is the product, a software available from Sun Nuclear for purchase at that time. Actually, I started using it in 2012, so it came available in 2011 or 2010 in that time frame. Atlas was used to establish a QA database for multi-modality radiation therapy center, which physicists can evaluate, document, approve QA tasks. The database has enabled, store, and manage all the QA documents in one system, allowing user with easy access from any networked computer. So rather than pulling spreadsheets, rather than pulling somebody's folder, rather than looking for where I have left it there, or when a transition happens, life is more uncertain nowadays. People move from job to job. So when we spend a majority of our time to set up a program, we have to transfer the legacy, as well as when somebody somebody come behind us, they should not be setting up the program again, because there is wealth of resources and the professionalism that we all are living up to should be transferable. The knowledge should be transferable. At the same time, the value of what we have done should be appreciated by others, the administrators, the vendors, and the inspectors and all that. So Atlas software from Sun Nuclear Corporation have the following features. We can set up and execute the QAs of multi-modality machines in different vendors, availability of library of tests based on the AAPM, American Association of Physicists in Medicine task group reports and applicable state regulations, possibility of creating new tests using Test Builder Suite. Basically, Test Builder Suite is an inbuilt program in the software where you can create your own spreadsheets and then do calculations as well as enter equations if it is necessary. For example, when I was doing my TG51, you guys may be calling it as TRS398. When I'm doing my TG51, I have a spreadsheet built into this program where I put the temperature pressure. It will calculate the CTP automatically, and then I put the measurements, the nanocoulomb measurements for 100 Nu, and then boom, my calculation will be done, and the output is given rather than going into a spreadsheet. That will stay there in this program, and then you can trend it also. I will show you the trend analysis tools and all that. And the same software, if I'm clicking daily, I can just put a daily QA check plus or daily any QA devices, and the interface will pull the data from the XML file of that program, and then I can actually, from my desktop, I can see what happened in the machine on that morning. Even if I am a little bit far away, if I am in a network place, I can of course see what is wrong in that machine. If the therapists are calling me early in the morning before I have started going to work, I can also look into the program and then identify where the problem is. I can give them suggestions, or I can even start a service call if it is necessary. And likewise, this is such a great tool in my fingertip, and QA program is under surveillance always, rather than, oh, let me wait, I'm coming there next week, I'm on vacation now. No, you have responsibility of your machine. You can take control of that anytime you want, and you can attach the documents to the database. So for example, every year here in the USA, all the registered Linux linear accelerators have to get a OSLD from MD Anderson. They have a program called RPC, Radiological Physics Center, and they send a calibrated OSLD. We calibrate our machine according to TG51, and then we expose it with the prescribed method, and we send it back to them within 1 to 2 weeks. They will send back a report telling whether our measured output, our calculated output is what is their measured output. If there is more than 5% difference, they will talk to us and help us to understand where the problem is and then to fix it. If it is more than 10%, they will come and visit. They will see whether there is any problem in our program setup and stuff like that. So that is the kind of quality assurance and community involvement we get through this QA program. So none of my patients, none of my machines in this last maybe like 13 years that I'm practicing medical physics never had anything more than 2%, anything more or less than 2% of the output. So tracking the calibration of, and when it goes beyond 2%, we need to tweak it the next month itself. So we need to trend it rather than looking back into the paper or a small piece of scratch sheet that I left somewhere. So this is the program where I go to. Tracking the calibration of equipment and storage of calibration certificates, customizable email reminders based on clinical requirements, daily or weekly review as required by the state internal departmental policy, keeping track of service activities and downtime of the machine. So this is basically a couple screenshot of my Atlas setup, where I set up all the machines and the users on the left panel, and on the right panel you can see this is my daily QA setup on a linear accelerator. This is one of my TrueBeam setup. And then here you can see my CyberKnife. I measure the, just like what I said, the output measurement is on a daily basis. We have to do it on a CyberKnife. So my physics assistant set up the chamber and the electrometer, connect them, and then he put the temperature and the pressure, and then he gives me 3 outputs in there, and it will calculate and see the % difference from my configured calibration output. And if that is more than 2%, it will turn pink. If that is more than 3%, it will turn red. So that I will get an email also as soon as if there is any problem more than 2%, I will get an email and I can call him immediately and ask him what is going on. And this is the trend analysis that I was telling. So I think this is like a quarterly verification that I am doing on each energy. Like you can see that I trend the 6 MV, and then I can see I can actually sign off, accept and approve these from here, so that electronic signature is there. Even the daily QAs that my therapists are doing, if there is any problem, they will system will alert me and they will call me, and even if any one of us miss it on a weekly basis, when I'm signing it off, I will be able to see if it is beyond my tolerance limit. So that's the advantage of this kind of program. So telling about the few, I mentioned that Atlas is going to go end of life soon. They started they actually upgraded Sun Nuclear upgraded their program to, they kind of abandoned this already, and they switched to a new platform called SunCheck, which I went to Sun Nuclear's factory or their training center, evaluated the program. We found that that is not sufficient for us. I think Atlas, I told them straight, Atlas was better than your new product because you have limitations, because they are still developing and they are marketing it and stuff like that. So we, as I mentioned, after a lot of research, we decided to go into QA Track Plus, and by the end of this year, actually, we are going to commission one more machine in this September-October timeframe. So we are going to wet our feet with the new program, the new QA program, which is QA Track Plus, by September-October. Once that machine is set up there, the QA program for the new machine is set up there and tested and analyzed, we are going to clone that machine to all our existing machines and other programs. And then we are going to roll over some of the data. We are working with them. Actually, if anyone need help with that, when you go to the QA Track Plus software, you can see the options to get some consultants and get help. Or if you are good in coding and programming and going through the materials published there itself, there is a lot of information and there is groups discussing all this. So this is our timeline and our plans as of now. With that, I'm done with my slides. This is our physics dosimetry team of the Miami Cancer Institute at the bottom. So just wanted to thank you all for being here and listening to my presentation. And if there is any questions, I'm ready to attend.
First of all, thank you, Siju, for sharing your experience with the other physicists from different parts of the globe. And this webinar is open for questions from the audience. And Siju, I would like to ask you whether what difference, I mean, what is the advantage you have observed in terms of the efficiency of the medical physics procedures when you moved from an ordinary way of doing this, the setup and the calculations and the data entry, everything using the the old methods to this integrated approach?
So as I mentioned here, first thing, number one thing, I never missed a test during the my monthlies are always monthlies, not bi-monthlies or tri-monthly. And then my annual tests, I can start early, I can fill up portions of it and then slowly and steadily work towards completion of it before the annual is ending. And all the trending and the trending especially helped me to identify the tolerance, because all of you who have been using TG142 know that the tolerance sets for different tests, for example, imaging or dosimetry tests are not having the same tolerance for daily versus monthly versus annual. So all those things, rather than looking and making sure I'm within the tolerance, I have my curves set in the software itself. The software will tell me, first of all, I need to configure all this. A physics input, there is, in our modern computer terminology, there is a proverb, or which we are using always, garbage in, garbage out. If we don't configure this thing properly, it's going to come out like garbage. So there should be an experienced person who has done the QAs at least a couple times, need to sit down and configure the software according to the need of your center. Once you configure that, the software will do the heavy lifting. It will remind us when the QA is due. It will be able to keep all the documentation that I am doing. It will do the calculations for me, so I don't need to pick up my calculator and do the calculation or anything like that. The software, integrated software, does almost 70% of my clerical work. I don't need to create a new document every time because the template is already there and the timestamp is there, and then someone can evaluate my work without looking at the paper. So all those are the big advantage. I would say my monthly QA on a LINAC, I can do comfortably with this integrated approach in about like 4 to 5 hours. I spent in my previous work, not in this current work because we have too many patients. I don't get lunch break to do the QA or anything like that. But in my previous work, after I set up this program, 1 noon during the lunch hour, I will go set up the water tank, do a TG51, do the dosimetry tests. the next day I will do the mechanicals, or the previous day I will do first I start with the mechanical, and then one of these days I will expose all the imaging QA, and then putting together the imaging QA result and putting together this document takes another 1 hour. So altogether in 4 hours I can complete a machine's monthly QA. So that was kind of a big time saver. That was kind of a less headache for me.
Okay, thank you so much. The next question is, did you find any issues when dealing with third-party softwares when installed on vendor platforms?
Oh, so the Atlas experience is totally different, because this is a purchased software from Sun Nuclear. So we put this in our hospital network rather than putting it in the vendor computers, because the vendor computers doesn't have nothing to do with our QA program. Our QA program is controlled by the hospital network. So I had to work with the IT department of our hospital to configure a database and put the clients on different computers that I want. For example, basically I put the clients in all the control areas, like all the linear accelerators control area, HDR control area, on the hospital PCs rather than the vendor PCs. And then in the database, when I'm connecting this, for example, I was talking about the daily QA integration. So in the backend, I will, using the DICOM listener, I can actually set up the program to look up the XML files coming from their software. So it was quite seamless, I would say, to set up this program first in Chicago, where I worked, and that's where I started in 2012. It took me almost like I could say about 50 to 60 hours of effort. But once I had that experience, I came down to Miami Cancer Institute. This was much more extensive program. Over there in Chicago, I had 2 Linux and 1 HDR machine and 1 CT. That was it. Compared to that, here we have, as I mentioned, we have at least 10 workhorses and other 5 or 7 peripheral devices. All that was kind of such an easy work for me, because I already have experience. I could say I spent maybe 30 to 40 hours setting up all this program in Miami Cancer Institute. Working with the software engineers of your hospital is much easier than working with the vendors, because the vendors wouldn't allow third-party software in their system.
Okay, and thank you, Siju. And the next question is, do you have a physics QA meetings?
Yeah, every month we have, especially in our department, with this kind of an extensive program. Let me start, rather than putting it in the big picture, let me go back to the small picture, because I know 60% of the practices may have like 1 to 2 machines, and we are running community practices. And there are university centers where they have more than 5, 6 machines. So I have experience in both the centers. So our previous practice in Chicago, where I mentioned I set up this program, the physicists and the physicians come together on a monthly QA analysis meeting, and we will simply open this program, and actually the physicist work would have been reviewed and signed by the chief physicist before that meeting, so that each one of us will talk how we did the QA, whether everything is fine. We can actually open up that trend analysis and then show the physicians as well as the medical director that everything is going well. And then in the annual gathering, like when we have the RPC report and all that, we just simply go into the maintenance section, open the RPC report, and show them that, okay, my machine is behaving in this last 1 year within 1%, within 2%, looking at the whole data from last 1 year. They are so happy. There is no point of opening folders or showing them paper or anything like that. This is your eyes. This is an eye candy for the administrators and the physicians to see that the physicists are doing such a thorough job. And likewise, in our department here at Miami Cancer Institute, every second Tuesdays, we have a 1-hour meeting because we have different teams working on different modalities. So we spread it out in a way that there is a group of people who will handle the ring-based gantries, for example, this the Radix Act, the MR Linac, and the 3 people in that group have 1 TrueBeam, and there is another group of people who will cover 1 TrueBeam, CyberKnife, and the CT machines, and basically that group also take care of the HDRs. And then there is another group of people covering the Gamma Knife, Icon, as well as 1 linear accelerator. And there is another set of people who will cover the Proton. So if we don't come together and present our work, everybody else doesn't have any clarity or any clue whether we have done our QA, whether the QA passed or anything like that. So on second Tuesdays in the afternoon, it is set in stone between 2 and 3 p.m. Every physicist will come together. We were physically gathering earlier, but in this COVID situation, we are coming in Zoom meetings and then we present our work. 5 minutes to 7 minutes maximum. We tell, show them what we have done, show them the report in the Atlas, and then if there is any attention that we have to do to that machine on that particular month, we have to explain to them, and then the physics group approve the work, and the lead physicist sign off the work from the team. That is how that is our QC program, quality control program. This is the QA program that we set up. Setting up the quality assurance program is the best that we have done for our quality control program. So our quality control program become tight and robust by the use of a robust quality assurance program.
Thank you, Siju. And I have a question, because do you use this QA software for doing the patient-specific QA as well?
Not really, but there are options. Actually, in the SunCheck, they integrated the second verification as well as the DVH analysis, patient-specific QA. There are all multiple tabs that you can, there are of course multiple licenses also that you can purchase and integrate it. But for us, in our external VMAT situation, we use the Varian IMRT QA using their flat panel. So it is much more integrated into the Eclipse system, where we analyze it and we put a document in the patient chart itself rather than putting it in the QA program. We were able to put it in 2 different buckets. Basically, the patient's data all goes into the patient chart, and the QA program, which doesn't have any patient information, will come into this QA program, so that we can give access to anybody. Like, for example, if I need to roll over this database into the new system which is coming, they are not going to see my patient information. Here, I know many of our countries require that we cannot share the patient data to anybody other than for clinical purposes. So we separated the clinical need versus the quality assurance needs into separate programs. And even the inspectors who comes from state or regulators who want to look for our QA program, they don't need to see our patient information. That was the logic behind it.
Okay, so you use ARIA for that purposes?
Yes, the patient-specific QA goes into ARIA documentation. Physicists sign off, physicians see it. Physicists approve, actually.
All right, thank you. And another question is, are you doing EPID-based imaging? That is the question number 1.
Yes.
Question number 2 from the same person is, I understand the software do things, but I would like to know what approach you use in Python to find the center or radiation field edges.
Okay, so that is actually, if you go to the PyLinac, I didn't start using Python. As of now, we are using RIT, radiation imaging technology, RIT software, which we will use for identifying the radiation isocenter and stuff like that. So they have built-in software where we use EPID based for our monthly QA and daily QA. All our images are coming through the EPID in DICOM format, and then we export it to that software and we use the analysis method. So if you have any questions about image analysis, this is a good source where you can go identify how Python is going to use it. So go to Pylonac and you can do all your MLC, picket fence, and your image analysis in this software. This is a totally free open source code, and they have their reference material there.
So there is a reference material which we can configure, or it is something which is a ready-made one which we can use? There is
a ready-made one. You can use a web-based interface, and they have all their documentation there, and there is a forum discussing all these questions.
Okay, and we can keep the server in our hospital, yeah, without keeping any of the data to the provider, I mean the software vendor.
Yes, you can actually simply use their web interface and save the data into your local drive.
That's really fantastic. So another question is, how many physicists present during dosimetric check?
Dosimetric check, are you talking about the quality assurance meeting, monthly QA meeting?
I don't think so, because during dosimetric check means, I think the question may be, this is a question from the audience. Mm-hmm. So he may be thinking the dosimetrical variations, I mean the verifying the treatment plan, or maybe verifying the QA results.
Oh yeah, okay, that's two separate things. As I mentioned earlier, we have on a daily basis our plans. The clinical thing is totally different. We have in the morning, we have a morning huddle between 8:30 and 9 o'clock. All the physicians and all the physicists and all the dosimetrists who are available at that time is supposed to go there. We, as I mentioned earlier, pre-COVID, we had physical meeting, and now we have Zoom meeting. Normally 100% of the people participate, where we have like a quick analysis of what we are going to see on that day in the clinic and what are the techniques we are going to use and stuff like that. And during the lunch time between 12 o'clock and to 12:30, maybe 12:45, the physics dosimetry physicians will come together and evaluate all the approved plans for that day, which is going to be used for treatment in the next day or so. So the planner will present it, and everybody is going to look into the details of it, and that is where we evaluate our contour also. Before the planner actually puts together the plan, the contour is reviewed. The physicians or the physicist, whoever, or the dosimetrist, whoever do the contour, they will have to defend their work, and the others do peer evaluation. That's clinical thing is on a daily basis. But this QA program, as I mentioned, all the people who have done the QA are supposed to present their work to the group. So it is, it is 100% in my opinion. Otherwise, in the worst case scenario, I'm busy with a project like, maybe doing a radiopharmaceutical or an HDR. My team member, as I mentioned, we divided in different teams. So the 3 people team have 3 machines. So my colleague will know what I have done that month. I will just brief him so that he can present my work to the others. So each team is supposed to present their work to the other team and get approval from the group. That's how we organize our QA program and our quality control program.
Thank you, Siju. And one more question from the audience. When you are checking output of the machine?
Mm-hmm. Every month. Daily QA does the output of the machine on a 10 by 10 field on a daily basis, and the tolerance for that according to TG 142 is plus or minus 3%. And on a monthly basis, I have to check with the water tank and at 10 centimeter depth. That is how we set up the program. with an ion chamber and an electrometer. So ionometry is done on a monthly basis. On a daily basis, on the DQA, daily QA3, we are using a diode-based approach. So if the tolerance on a monthly basis is plus or minus 2%, we tweak it. We tweak it down to close to 0, and then we check and we keep an eye on that on a daily basis. So that's where this trend analysis have such a significance. So we have a quick and dirty, or I cannot say dirty, quick and easy tests by the daily QA, and a solid, robust test on a monthly basis with the typically I'm using the protocol, the TG51 protocol every month to see that my machine's output is within 2%. If it is not within 2%, I tweak it. On the annual, even though it is only 1%, I tweak it down to 0. I rebaseline everything. All of my QA program will be rebaselined depending on the annual QA. So daily, monthly, and annual, I check my output.
Okay, thank you, Siju. And there is one more question from the audience. Can you please elaborate about your annual QA methods, and maybe can you please summarize about some of your annual QA approaches that you follow in the center?
Annual QA itself is a big topic. Actually, in the TG142, if you guys are able to pull that out, you can see there are 3 separate areas of annual QA. So as I mentioned, pretty much all the physics QA program is divided into dosimetry, imaging, and mechanical. So annual QA will start with a thorough mechanical evaluation. We even check the ISO center with the vendors. That is the first thing we do, and then all the details of the machine's characteristics, like the jaw, the MLC, the table positions, the tables, rotation, crosshair, you name it. Everything that is mentioned in that test, we go through that. And then we put the water phantom, the 3D water phantom, and then we do spot checks. Actually, we have a subset of PDDs and the TPR, as well as all those information, and then we take the output factor at different positions and stuff like that. So I have a spreadsheet which we developed in the last 10 years from TG142 era, and also we update that on a regular basis every year when because we have a big group now, we go through that again and again and make sure we are up to date. And if there is something more the team has to propose, we make that sheet up to date. That sheet is integrated into this Atlas program, so I can pull it out and then start filling up, and then you can leave it alone there, and then maybe 1 week later I can go catch up from where I left. So the mechanicals, once the mechanicals and the dosimetry verification is done, I will do my imaging QA. Imaging QA is also very thorough. I will go through all the required tests that is mentioned in TG142.
Do you also follow TG275 for your patient treatment, chart verification, beam verifications, those kind of?
Oh yeah. Okay. Actually, we have for the patient specific QA. I didn't focus on that aspect in this lecture. Patient specific QA is totally a different beast, which we follow all the requirements by.
No, my question is, do you use the same the QA sheet for recording those information, or that will go to a different vendor's software?
Oh, actually, vendor software is a configurable tool for putting what you want. Basically, the TG, whatever TG requirements like TG66, TG148, TG135, TG275, the physics group or the physicist in charge have to read through that, understand the need of that specifically according to TG100. The physicist is the is the person who is in charge of the QA program. So we evaluate all that, discuss it in our group, and then we incorporate the tests into the software. So we don't really depend the software to spit out the test that is necessary for us. We, the physicists, decide this test should be done for our program, and then we incorporate the test into the software, which will remind us, okay, this is the time to do it. Do your monthly, do your daily, do your annual. That is how we incorporate. We use the software for executing all the tests that is agreed and approved by the internal QA program. So we use TG100, TG275, all those TGs we select, and we pick and choose what kind of tests we need to do for this particular machine. And that's the advantage of the software. Rather than just depending on one particular document, you can actually harvest the best out of multiple documents and put it together in your fingertip to use.
Thank you, Siju. And there is one more question, another question from the audience. Will this reduce our time doing FMEA and root cause analysis? Kindly, can you share your experience on this?
Yes, actually, you can see, for example, when recently, let me tell you an experience of my Linac maintenance. Actually, one of the Linac TrueBeam 5, we had some issues with the CBCT. We were seeing some artifact. So I was actually able to fix it by doing a flood field and dark field correction, and then reset all the QAs, all the baselines in December 2019. We were able to do that, and then 3 months later, the same issue populated, and then I pulled all the documents from that 3 months before, because I was able to put it in the maintenance section. All the information that the field service engineer gave and the communications that the variant engineers provided, I put all of them together there, and I had physics resolution documentation also there. So then 3 months later, when it populated, I showed the FSCs, and because variant sends different people to do the service. So I told them that this is the situation, this is what is happening with the machine. Then finally, the vendor had to find out that one of their in their detector, they had to replace the panel. So we were able to use the QA program to backtrack the problem, and we were able to do a root cause analysis, and we were able to fix the problem much more easier than waiting for this thing to fail completely, because I had records and I know where to look for, rather than checking and making sure that the issue is resolved only after a failure. And MLC's picket fence is giving us a good idea, a clarity about which leaf or the nuts or the bolts need to be replaced before it fails. It is such a pain in the neck to replace an MLC during a patient treatment. So if one of the leaf set is actually lagging and showing some kind of problems in the monthly QA, I would tell my FSC that I have a problem with this particular leaf set. Why don't you go ahead and replace that for me? And then he will do it, and then I can just simply run another picket fence, and then done. My patients will not get interfered during the treatment for that. And likewise, in my CyberKnife, almost 2 years before, the magnetron magnetron had some issues. Magnetron was replaced, and then this year, while I was traveling to India, the magnetron broke again, and then the group didn't have any clue what to do, what kind of QAs we have to do after the magnetron is replaced. I was in India, and then I got a text or a WhatsApp message from my colleagues asking, Siju, can you help us to accept this magnetron replacement? And I said, 2-3 years before, I have the documentation put together in Atlas. Please go ahead, review it, go through it, and if you have any questions, I will be ready to help you. I can call you and talk to you. I never got a call back. I was able to peacefully enjoy my vacation in India.
Thank you,
That's all.
Siju.
Yeah.
Thank you. Thank you. It's a wonderful experience you have.
Mhm.
And another question from the audience. Do you have any experience on Electra Aqua software? Did you
That's one of
customize?
the, no. I never used it. That is one of this. Actually, I should have included in my list. Aqua is actually a good software. I worked in Electra um, Versa machines for 2 to 3 years. During that time, I encountered the Aqua software, and that's a good program. I have no complaint about that. I have good experience reviewing it, but I didn't thoroughly check it this time because we have, in our current practice, Electra is not heavily used.
Okay, so you never customized. You
I never.
use the way they provided.
Yeah, no, we didn't have anything variant provided. Variant.
No. My question, the question was whether you customized that or you use the way it was provided by Electra without any customization.
No. Aqua. I never had access to that software. I just reviewed it with the vendors. That's all.
Okay.
I never had used it for my clinical practice or QA program.
All right. Thank you. So I thank you, Siju, for supporting this campaign while volunteering, lecture, and sharing your knowledge, especially in setting up a medical physics QA program in a multi-modality radiotherapy setup. So I also thank all the applicants for your active participation and with the questions, and welcome you to all the future webinars. See you again. Thank you.
Thank you very much.